Good evening, everyone, and welcome to this British Society for Haematology webinar. I'm Stephanie Tweedale, I'm Head of Education at BSH, and I'm very pleased to introduce this joint webinar this evening with the National Non-Hodgkin Lymphoma Audit Team, Improving Data Quality. So we'll get the webinar started with some introductions and housekeeping. So I will hand over to Dr. Kathy Burton, who is a BSH trustee and the NNHLA Clinical Lead for Haematology.
Thank you very much indeed, Steph. So welcome to you all. As Steph said, this is based on the National Non-Hodgkin Lymphoma Audit. And what we're really trying to get out of this evening is to talk about how we can improve quality in terms of the data that's provided to the audit that will then ultimately influence the data that we collect, and therefore how we can improve treatment outcomes for patients. So I'd like first of all to introduce all my colleagues that are on the call. So as Steph said, I'm one of the co-clinical leads on the haematology side. I'd like to introduce my other co-clinical lead, who's David Cutter.
Good evening, everyone. I'm David Cutter, as Kathy said. I'm the co-clinical lead and I'm a clinical oncologist from Oxford rather than a haematologist, but I treat lymphoma. It's my main specialty. And my other hat is also research using routinely collected data at the University of Oxford. So this is obviously a topic that's close to my heart.
Excellent. Thank you, David. Kate?
Hello, everyone. I'm Kate Walker. I'm a Professor of Medical Statistics at London School of Hygiene and Tropical Medicine and at the Royal College of Surgeons of England, and I'm the Senior Methodologist for the Non-Hodgkin Lymphoma Audit.
Excellent, thank you. Vicky?
Good evening, everybody. Thank you for joining us. My name is Vicky. I'm the Senior Project Manager for this audit and also for the National Pancreatic Cancer Audit at NatCan.
Excellent, thank you. And Lou?
Hello, everyone. My name is Liu Han. I'm the methodologist on this cancer audit, and I just mainly work on the data side of the things. I am a statistician from at the London School of Hygiene and Tropical Medicine.
Thank you. And Fane?
Good evening, everyone. I'm Fanny Chen. I'm the project coordinator for the National Non-Hodgkin Lymphoma Audit.
Thank you. And then Simon, if you could introduce yourself from NHS England.
Yeah, good evening, everyone. I'm Simon Cairns. I work for the National Disease Registration Service as a data liaison manager. My role is to help trusts with the data collection, and I'm here representing the team tonight.
Excellent. Thank you very much. I think I've included everyone. So the intention really of this evening is to have a number of presentations with and then Q&A, and really what I'll try and do, and between us as the group, is sort of answer the questions that are specific to each particular person and their role of expertise within the audit. So if we could just move on to the next slide, because there's just, yes, some just an outline and then also just some housekeeping. So Kate will be giving the first couple of talks, which really is about the sort of background to the audit, and then this particular focus that we're talking about today, which is quality improvement and therefore data quality. And then Vicky will give a case example from a well-performing hospital, because we're very keen during this audit to learn from hospitals that are doing very well and to try and understand why some hospitals perform better than others, and therefore how we can help everyone generally across England and Wales. Then Simon will be talking in terms of his role and his involvement with these quality improvement plans, and then we'd very much like to talk about next steps and then take some Q&A, but happy to take some questions as we're going along. So as I said, I've probably spoken about this, really sort of the objectives is to increase the awareness of the audit itself. And some of you may be familiar with the data dashboards, may have looked at this yourself, but it's just, this is an opportunity really to go through this with you, how you can use this as a key resource for your particular trust, and also to look at the performance indicators and audit outputs associated with this audit. And then also to provide details of the quality improvement intervention plans. Just a little bit in terms of housekeeping. We have asked the speakers to mute their microphones when they're not speaking. Please do feel free to use the Q&A function. So would prefer you use that rather than the chat function, although we will keep an eye on that too. We'll try to respond to some of the questions between each part of the session and at the end of the presentations, but there'll also be a Q&A section at the end as well. And also we'll highlight this again at the end, but you are invited to email us if you think of subsequent questions via our email address here. And just to point out that CPD certificates will be issued to all attendees after the event, and just to note that this webinar is being recorded. So thank you very much. So I think now we should be able to move on to Kate's talk. So Kate's going to introduce the background to the audit. So thank you very much, Kate.
Thank you very much, Kathy. Just a little bit about the National Non-Hodgkin Lymphoma Audit, who we are, what we're trying to do, the performance indicators that we're reporting on, and our outputs. NNHLA is one of 10 national cancer audits in NatCam, the National Cancer Audit Collaborating Centre, which is funded by NHS England and Welsh Government. It's been funded so far on a 3-year plus 2-year extension. So we're currently funded until the end of September 2027. And NatCam was set up in October 2022 as a new centre of excellence in the Clinical Effectiveness Unit, which is a collaboration between the Royal College of Surgeons of England and London School of Hygiene and Tropical Medicine, which is where we form our clinical methodological partnership. This is the team, and you'll see quite a few of us in the webinar today. Our partners are BSH and the Royal College of Radiologists. We have a clinical reference group, which is chaired by Rupinder Gill, and our charity partners are Lymphoma Action and Blood Cancer UK. We also have a patient and public involvement forum, which is chaired by a patient, Frank Burrows. So the aims of our audit are to provide regular, timely evidence to cancer services of variations in NHL care in England and Wales, to identify reasons for the variation in NHL care and help guide quality improvement initiatives, to stimulate improvements in NHL detection, access to treatment, and outcomes. We report on up to around 10 indicators per audit, and our first reporting began last year when we reported these indicators: whether or not patients were seen by a clinical nurse specialist, whether they were discussed at MDT within 4 weeks of diagnosis, high-grade NHL patients starting chemotherapy within 62 days of referral, high-grade NHL patients starting radiotherapy in 8 weeks at the end of chemotherapy, receipt of radiotherapy, and 2-year and actually also 1-year survival of high-grade NHL patients. We also report survival for subtypes of all subtypes of NHL. And then we have got a further set of indicators that we are developing, and we've added 3 more this year with more to come. So 2 more indicators this year: proportion consented for a clinical trial, first-line chemotherapy treatment regimes for high-grade NHL, and a new contextual measure, the proportion presenting in an emergency. We report annually our State of the Nation report, and the second of those was published this September. That reports on these performance indicators nationally and at individual NHS Trust and Welsh Health Board. And in England, for this year's State of the Nation report, we've been reporting on the year 2022. And for Wales, we've been reporting on the year 2023 because of that, but that's the data available to us for those countries. We also have quarterly data dashboards and a State of the Nation data dashboard, and I'll be showing you how to find those. So the quarterly dashboards, we update those every 3 months for NHS trusts in England. There is no quarterly reporting for Wales just because there is no rapid cancer data available for Wales. And there's about a 6-month lag in those quarterly dashboards because we're using this rapid cancer registration data. We report on data completeness over time, data completeness snapshots comparing each trust to its peers, and performance indicators over time. Our State of the Nation dashboard, published annually at the same time as the State of the Nation report, and that is for England and for Health Board in Wales. And there's a much longer lag there because we're using the gold cancer registration data. In that dashboard, we report data completeness, snapshots compared to peers, performance indicator, benchmarking compared to peers, and some tumour characteristics. The quarterly data dashboards are particularly relevant for what we're talking about today because we're aiming to use those to drive and monitor local quality improvement, starting with data quality. So to find our dashboards, go to the NatCan website and find data dashboards. Here's what the quarterly dashboards look like. So your performance indicators over time there as a control chart. Data completeness over time with a target of about 90% completeness and data completeness snapshot compared to your peers. So these are interactive dashboards where you're able to select your own trust and compare it to others. I'll pause there.
Thank you very much, Kate. So just to remind you, do put questions into the Q&A, but I haven't got any questions at the moment, Kate, so I might just pose one to you. In terms of the sort of performance indicator you've talked about, which do you think is most challenging, or what's the one that you think you'd really like to see improvement with?
In terms of, I mean, we focus on variation in care, and we're also focusing on the overall performance nationally. We focused in on the time from referral to starting chemotherapy for the work of NHS England's Treatment Variation Working Group, because actually the performance there nationally overall is poor, where we've got a low rate meeting the target there and wide variation between providers.
Yeah, and I think that's a really important point, Kate, isn't it? Because we're really trying to identify where there is wide variation, why, and how we can address that. So that's, thank you. So Kate, shall we move on then to your next talk, and then we can take any further questions then?
Yeah, that's good. And so really today we're focusing on data quality because that's the topic of our quality improvement intervention. Each of the audits in NatCan is launching a QI intervention, working with providers. We're trying to move on from just measurement and reporting to improvement. And we focus, as I say, on data completeness, and I'll explain why that is. So obviously, we need high quality complete data to identify where care pathways need improvement. The objectives and remit for our quality improvement intervention to improve completeness of data submissions from NHS trusts in England, to enable equitable benchmarking across providers and enhance the accuracy of audit reporting. Here's our chair of our patient forum, Frank, who says it is vital that people's care and experiences are fully understood and measured fairly. Without complete data, important issues may remain hidden, leading to missed opportunities for better treatment and support. Couldn't have said it better myself, so thank you, Frank. So the aim here is that together with key stakeholders, the audit has agreed to focus on improving the quality of data for staging, and that is in terms of Ann Arbor staging and BNA staging, and also the International Prognostic Index. In partnership with NDRS, our data providers for England, what we are doing is providing bespoke feedback to any trust less than 50% completeness on Ann Arbor staging. Actually, when you look at those trusts, you'll see that they have even lower completeness on the other two. So that's the reason for picking that. And what will be provided in that feedback is individual results for the trust compared to peers, links to our dashboards, supplementary materials to help local quality improvement, and links direct to your local NDRS data liaison manager, and you'll be hearing from a data liaison manager later on. And the idea is that we will re-evaluate engagement and trust performance at 6 months and again at 1 year. So the bespoke feedback will provide comparisons to the whole Cancer Alliance of the Trust and to the national data completeness. The target will be around 80 to 85% completeness, and we'll be describing how things are changing over time. So we'll be sending out these emails very soon. We've got on our webpage more information, so please do have a look at our quality improvement pages there. And I'll pause there, Kathy.
Excellent. Thank you very much, Kate. And I think it's important to make the point that we all realise this isn't easy. And speaking from personal experience in the Leeds MDT, you know, we don't always collect the staging data or share it. And I think it suddenly actually putting a focus on something like this actually makes a huge difference to actually overall quality improvement. And I think it's something that we need to all engage with, you know, in terms of the clinical leads in the MDT, the clinical nurse specialists, the MDT coordinators. I think that will really help us improve this data collection. And very much, as we've said, this is a sort of work in progress, so acknowledging that there's centres at the moment that aren't achieving this objective, but that we're hoping that over time we'll see a significant improvement and see that trend, which will be really pleasing for all of us. So thank you, Kate. So I can't see any other questions at the moment. So maybe, Vicky, it's a good opportunity now to talk about a case example of a well-performing hospital and what we all can learn from what they're doing and how we can apply that into our local trust. So thank you, Vicky.
Thanks very much, Kathy. And just to explain, I'm presenting on behalf of our colleagues at Homerton University Hospital in London, who unfortunately weren't able to join us this evening, but we have been in discussion with them, as I shall explain. So the hospital was identified by the audit team as a hospital doing particularly well with completing the required staging data fields that we're looking for. And so it seemed a sensible idea to reach out to them to find out what it is that they're doing, with the hope really that we could pick up some tips which might be helpful to other hospitals. And so we had communication with their hematology MDT coordinator and also their cancer performance manager to see what those areas of potential shared learning might be for other hospitals. So with regards to their local QI initiatives and what the team were doing, we found that the MDT coordinator really plays a very key role in ensuring the completion of the staging data. And with regard to their internal data quality processes, they explained that there were several things that they did, and these were as follows. So it might be a simple thing, it might sound a simple thing, but they set themselves Teams reminders just to remind them during a busy day that there was a need to start completing missing data. They advised us that they also sought updates from the consultants to get the information that was needed with regard to staging. And they also took the initiative to share a list of diagnosed patients where the staging information was needed so that these could be completed and ready by the date required. We spoke with the cancer manager at Homerton and asked her, what are the strategies that you think are taking place that are adding to this data quality success? And she advised us that they escalate where further input is required. They identify and share specific details where there are any fields that are missing. And finally, and perhaps most importantly, undertake a final check through all of the data fields before submitting the data. So making sure that everything is as it should be and in good time prior to submission at the end of each month. Thank you, Kathy.
Excellent. Thank you very much. Thank you, Vicky. I just wonder for people that are listening, if there's any comments that they have on that, any areas where they find that particularly difficult, challenging in their own trust or own MDT setting. I don't know if anyone's happy to add that. I think one of my maybe pieces of advice would be it's generally much easier to do it at the time, i.e. in the MDT, where maybe the radiologist is there, so you can actually collect all that data at that particular time point. And I think the other point the Homerton team made was just chasing and really hassling the clinicians to provide that data. And I think that is really important, and not to be concerned about doing that. I don't know, David, what you found from Oxford. Have you got any experience that you can add to this, or where you think you've been successful?
Well, I can't say we're terribly successful at it. And, I think the reason for that is that many clinicians sort of approach the MDT with a doctor's hat on. They've got a job to do and they want to discuss their patients. And sometimes the systematic approach and the data recording can fall a little by the wayside because they're so focused on that clinical side of it. But I really hope that we can improve what we do in Oxford, because it strikes me as a win-win, really. We can see from the Homerton example that a systematic approach with some very simple sort of measures to try and drive that forward can make a big difference. And everyone would benefit from that approach. We get better MDT outcome forms that we all rely on to direct and decide what we're doing with our patients. But just doing that process of the meeting and recording the process of the meeting to a higher standard will be beneficial in itself, but almost as a byproduct will result in an increase in the quality of the routinely collected data, which we rely on in the audit and in research as well. So I really think it's a valuable thing from all sides.
Yeah, thank you, David. And I think that's right. It does require, though, engagement. There's no doubt about that. It does require engagement from the people in the room at the time, and then sort of subsequently if you're hassling people afterwards. But as David says, I think it does actually improve overall the MDT outcome, in terms of actually, ultimately this is about data, but then this is actually about how patients are being managed and that they are being managed appropriately. So I think that's really important. Okay, Vicky, I think that was an excellent example. So thank you. I don't see any questions yet. Do put some questions in the chat. I'd love to have at least just one question. That would be excellent. So, but Simon, shall we move on to you as our data liaison manager? It's really useful to understand your
Absolutely.
side of things. Yep. So hopefully you've got your slides here.
I will.
Yes?
I'll just
Okay.
share them now. If you can just let me know if they're on screen, that's great. I did just put one question in the chat as well. So I'll answer that at the end if that's all right, just in case that's beneficial. But hopefully you can see that on screen. If someone can just give me a little yes, that'd be great.
It's fine, Simon. Yeah.
Perfect. So thank you for inviting me this evening. I'm Simon Cairns and I work as a Regional Data Liaison Manager. I'm here tonight representing the whole team, which covers the whole National NHS Trust. And we are here to discuss how we are going to play a part in the quality improvement plans around NNHLA, but also around our COSD dataset as well. We've got kind of a pretty short amount of time today, so I'm going to give a bit of a potted history, and I'm happy to take questions at the end of either this presentation or later on the meeting. Hopefully it's not too fast moving, but just to let you know who we are if you're not familiar, we work for the National Disease Registration Services, which logs cancer data nationally, is currently part of NHS England. We receive multiple submissions for every NHS trust in the country around cancer data. One of the main ones that we handle is the Cancer Outcomes and Services data set, shortened to COSD or COSD. It is the largest cancer data set in the world, so it gives us a wealth of information from demographics through diagnosis, stage, pathway events, MDT treatments, living with and beyond cancer. It is really, really informative. And our organisation analyses all that incoming data and curates it so that we've got a number of reporting suites available that gives you granularity on data completeness at a national level, Cancer Alliance level, individual trust levels, and also individual trust tumour levels as well. Now, recently, since certainly at least February 2024, we have linked up with NatCan for them to use our COSD submissions to source the data as part of their methodology, which obviously now includes the NNHLA audit. One of the things that my team exists for is to help facilitate improvement in NHS Trust documenting of their cancer data. So we're working as a bit of a two-prong approach to improve COSD completeness, because that will improve the audit data as well in the future. Our liaison managers, myself and my colleagues, have worked with all trusts nationally on some element of data improvement, if not all tumour sites that they encompass. And we've got a number of success stories, which I'll touch upon, about improving haematological data collection as well with some trusts. Obviously, we've mentioned staging quite a lot already this evening, but yes, we're focusing on the Ann Arbor and the BNA collection, as well as our ISS, which I'll quickly mention for myelomas. So I'm going to give you a bit of a background as well about how the data completeness is currently. And you might be thinking, well, where are you pulling this from? What are you referencing? So I just also want to give you a little bit of background that there are current available resources that show data capture for current diagnoses, and I'll be showing you those in a moment. We do keep our registration service somewhat open for up to 12 months from date of diagnosis for patient records to be updated, and those updates to be sent to our organisation. So by no means are some of the current figures that I'm showing you stopped or closed or frozen. They are still available to be altered if there is more data collection or more information to be given to us. What we have learned very quickly is, obviously, if we get the COSD improved now, we improve the data completeness for future State of the Nation reporting, as well as what was mentioned before previously by my colleague, those quarterly reports that use the rapid data as well to formulate those outputs. So the COSD data is submitted to us monthly as a mandated submission, and on the first working day of every month, myself and my colleagues contact every single cancer services manager in the country with a tailored monthly feedback report, which I'll show you in a moment. We also have the Cancer Stats 2 platform available, which is our online website if you need to go and access it and cut the data down, but you do need an account as an NHS employee. And we do also have a public-facing dashboard as well, where no account is required. I will say, if you're going to go and source data after this meeting, the Cancer Stats 2 platform is updated daily, so any information we receive is kind of reflected within 24 hours in the stats, whereas our public-facing dashboard is only updated once a month, so might be a little bit in lieu. So, for example, the monthly feedback report myself and my colleagues send to all trusts goes out. Here's a synopsis of the report. It is more detailed if you get the whole thing, but it breaks down per trust, per tumour level, how good the staging completeness is on a bit of a RAG rating. If it is in the cobalt blue, it's 80% or more. If it is in the grey, it is between 60 and 80%, and anything under 60% is highlighted in red. I've got one of my trusts I've put quite a lot of work in over the years, which is the University of Derby in Burton, and you may notice that their 3 haematological subsites for myeloma, CLL and lymphoma are all over 80% for staging. What I will say though, and this is using the example of the Cancer Stats 2 report, which is updated daily, if I look at the last 12 months for the whole country, you'll see that those haematological subsites are actually some of the less well-staged tumour levels nationally. We've had a number of approaches in the past to try and improve them, so this is somewhat of an improved state, but there is still a long way to go in terms of the amount of data capture that we actually need to go and assist with. We will obviously put you, as previously mentioned, in the direction of the NatCan State of the Nation reports because they are really, really useful and are really good for the retrospective diagnoses if you want to go and see from the gold standard data how well your trusts are performing as well. So one of the things we've done when we've tried to improve things previously is we went to trusts to get some commentary on why haematology cancers aren't always staged and documented so well. There is a whole spectrum of feedback that we've had. So I've just put a few examples on screen now. It is a complex tumour site. We know the cancer management teams involved in monitoring data completeness aren't always au fait with what actually needs completing. We know that haematology is quite often a smaller tumour site in trust, so it's often deprioritised. You might have inconsistent cover at MDTs. You might have rapidly changing MDT coordinators who aren't trained up on the medical terminology. You might have your MDT coordinator who splits covering haematology with other tumour sites as well. We know from all cancers as well, in terms of staging completeness, that quite often management teams struggle to find an opportunity to review the data prior to it being submitted to us. And that can be a little bit of an issue fitting that into the working week. We also know that relevant training is not always given to some of the admin members around collecting some of this medical terminology. So what we know is we've got a bit of a consistent issue, which is haematology subsites seem to have a bit of a problem where they're not necessarily capturing the staging data as efficiently as they can. What we have learned as well, though, that there's a whole spectrum of reasons why that occurs trust for trust. And from my experience, you can drive 10 miles between two neighbouring hospitals and have the same problem, but completely different reasons behind it. So what my organisation is planning, obviously in relation to working with NatCan and in identifying those 50 trusts who could potentially do with some improvement, is we are coming in to try and improve the data completeness by offering a form of support that is flexible and that meets the individual trust needs, whatever they are, through the methods we identify them. So what we feel as an organisation is there's a little bit of a tripart responsibility for actually submitting the stage to us. It kind of reflects on the consultant, the MDT coordinator staff, and the cancer services management as well. And we kind of find, certainly from experience, when we've found trusts who aren't very good at documenting this stage, there's a little bit of a breakdown between those three members of staff quite often. And that's where we step in and we try and fix that disconnect and try and make processes better so that the data obviously gets improved. I'm not going to read these verbatim, but obviously in terms of the consultant, we know your main role is there to identify and communicate the stage of the patient's disease. There are some considerations within your role about, are you doing things appropriately to make sure that is communicated well? Or are you making it clear that you are communicating stage during your MDT? Or are you looking to kind of involve another process in terms of actually recording it, perhaps through clinical letters and documentation, things of that? Are you making yourself available to have discussions with your MDT coordinator or your cancer services manager who might be reviewing the data? And one of the key things is, do I actually know how my individual trust is performing in relation to the stage and capture? From the MDT coordinator point of view as well, we quite often look at their role, which is to input the given stage correctly in the trust cancer database. And we know there's a number of considerations they need to look at, which is obviously, are they aware that the stage is being given to them? Do they recognise it? Are they aware pre-MDT who they need to be looking out for this information for? Are they physically asking for it if it is not being discussed by the clinical members during the MDT discussion? Is it being recorded correctly? Are they contacting CNS staff? So again, there's a bit of a spectrum. There's a number of reasons why this can fail on, say, the MDT coordinator point of view. And we come in and try and have a look at your process and see where it might be falling down. And again, with the cancer services manager, we do put quite a lot of responsibility for our cancer services management teams to be reviewing the data before it's submitted to us. Quite often in the past, cancer managers would just send the data off and then wait for our monthly report just to see what it looked like. We strongly encourage, curating and quality assuring your data before it's actually submitted. And again, we can come in and assist with that. There's obviously quite a lot to consider as a cancer services manager. I speak from doing the role previously myself, but there are opportunities where you can step in, actually look to support with the data collection. We're trying to introduce a bit of a robust process, and with the 50 trusts we identify for NNHLA data completeness, we are going to try and introduce looking at where that trifecta of responsibility might be falling down. I know these slides will be shared with you, so maybe you can have a little look at this diagram in greater detail than the time we have at the moment. But there's a number of opportunities in the patient discussion timeline where the responsibility of considering stage, declaring it, documenting it, curating it, quality assuring it, falls between those three members of staff. And again, we can assist on any part of that. We will come in and we will help you with that. That's where myself and my team obviously come in. We are looking to offer any improvement work that we can. We are really keen to hear from any trusts. We are keen to try and offer some insight and share best practice, because we do have those stories where trusts have gone from being quite poor to really, really good at data collection. Obviously, we've had Homerton use as an example, and I showed Derby and Burton before as well. Some of the considerations from my side is, what can I offer, be it virtually or, on site? Can we offer training? Can we discuss medical terminology? Can we teach you on your cancer database where to effectively complete the information? Can we come in and help with your current process? Do we need to come in and speak to your clinical leads to see if they are considering how they are maybe declaring or lack of declaring the stage at MDT? So a really quick example of this is as recent as last Friday, which one of my trusts, which is Bradford Teaching Hospital, which is great. My colleague Kate pulled up the West Yorkshire and Harrogate Cancer Alliance on one of her earlier graphs. There are areas of improvement to be made, and I finally sat down with their new data manager last Friday, and we looked at all the lymphomas, not just non-Hodgkin lymphoma, but all the lymphomas that were stageable for 2025. The start of that meeting, their current lymphoma staging for the whole calendar year was 56%, and we identified there was 30 unstaged lymphoma patients. We did a bit of a two-prong approach again. We sat and audited the cases together virtually, but we also sent out some emails to our consultants after the fact, in some cases quite long after they'd been discussed at MDT. But within 3 hours, we'd found 22 of the stages for those 30 unstaged patients. And now we're looking at a new aggregated lymphoma performance of the year to 88%. So this is as recent as last Friday, 3 hours work, and we can come in, identify problems in the process, and also improve the staging data as well. One of the takeaways was my consultant actually said by email, I'm really glad you've reached out and told us we've got some gaps. More than happy to provide the information by email to you, but obviously we don't want to clog up our inboxes. We are quite busy. So now Bradford Teaching Hospital are adopting a process that Derby and Burton Hospital put into place about putting a summary in their clinic letters that they will dictate when they see the patient post-MDT in clinic, just so there's a really quick and auditable resource for our non-clinical staff in cancer services to access. And that just keeps things flowing efficiently. We get the data we want, but we don't introduce multiple steps that clog up people's time. So again, we know that there is a consistent theme that the hematological cancer data is not being recorded great for staging at the moment. We will adapt our processes to your needs, and we really encourage you, if you're here as a clinician, to speak to your cancer services manager, learn your position, learn what your data capture looks like, but also reach out to us if you want some improvement work as well. I'm going to stop sharing now, but I will just quickly answer the question I seen in the chat earlier, which was around the percentage being 85%, and is there any particular reason why it's not 100%? Well, from auditing the Bradford cases last week, we found that 2 patients, for example, had been admitted through A&E, had been admitted to a ward, and sadly had passed away in a number of hours before any diagnostics could really take place. So I think it's a fair aim to get to 85%, because you will always have those cases that are just unable to be staged just because of the rapid presentation of a patient and often the unfortunate decline before we can have any kind of intervention. And also I noticed in the chat there was a comment about, is there an attempt to gather data and understand if trusts that have a separate new patient clinic do any better? I think because the data completeness for hematological subsites in general has been quite poor, we're not really able to make that analysis at this point and say this is definitively better in this circumstance rather than other types of clinic arrangements. So I hope that answers the question to the person who submitted it in the chat. But I will stop there and pause if there's any immediate questions.
Excellent, Simon. I think that was really, really helpful. As a clinician who sits in an MDT, hearing from you how you can help our MDT do better at collecting this data, I think was really important. And I think really nice to hear that you appreciate what the difficulties are and also presenting different solutions. James, who's put a comment, who I know well, said, you know, it's the constant challenge of a busy MDT, and it is, and the software issues that you've got. But actually, as you've laid out, there's a number of sort of steps in the path where the patient management, whether it's in the MDT, whether it's in the clinic letters, that this can just be easy identified. Because actually, James has made a comment, the most important thing is getting the best possible data into the submission. That's what's key, and I think that's absolutely right. You know, sometimes the MDT setting isn't the right place, but when you've got all the information, you put it in a clinic letter, then it's easy for people to extract that data. So that's a really helpful comment. So no, thank you. And you know, and one thing James has just raised is different MDT coordinators, and I think that is really difficult, and that's why we need people like you coming in all the time, because you're used to working with one MDT coordinator who works in a certain way, and then you have different MDT coordinators not familiar, as you say, with lymphoma, and that can make that really difficult. So I think being able to link in with someone like you is really helpful. So thank you. I was just going to see if there's any further questions. Yeah. So I just saw a question pop up. So the person who asked the question about the targets, yes, yeah, she's answered that. You've answered that, so thank you very much. I think that's an interesting point about the new patients clinic. I'm honestly not sure how many trusts do that in the sort of hematology and lymphoma setting. I know, for example, we don't in Leeds. I think most clinics run both new patients and follow up. So but it would be interesting if that does happen at a number of trusts, whether that helps, where the focus is, you know, on new presentations and therefore the stage. Kate, did you want to make any further comments on?
Just to say massive thank you, Simon. I found that really fascinating and helpful, and heartening to hear that it can do so much improvement in a short time. So yeah, I'm feeling really hopeful about our quality improvement intervention.
Yeah, I think it's really good, and I think it will benefit all parties, you know, not just on this call, but those that also haven't joined. The more insight we have from the data, you know, the more we're going to evolve our services, and that's only going to benefit one bunch of people at the end of the day, which is the patients. So I am like you, Kate, I'm quite enthused about where we're going to go with this and what the outcomes will be. So I can't wait.
Yeah, no, I think that's really important, because I think in lots of trusts, and maybe ours is one example, the sort of cancer centre and the data collection service is quite separate actually from the clinical service, and actually someone like you sort of coming in and linking up the two, I think actually really helps. So thank you for that. David, did you want to make any further comments? I don't know if you've got any examples from Oxford.
Yeah, just to add to the general thank you and the great ideas, really. I mean, I know we focus on the MDT as the main source of data collection, but simply the idea of trying to encourage our colleagues to be a bit more systematic in dictating letters and recording stage would give another very useful source for the data managers to go back to and harvest this valuable data. And even just, you know, sowing that seed of an idea would help improve our data collection in Oxford for sure.
Yeah, I think that's an important point, and I think that's actually a way of educating the trainees coming through at the moment how important this is, because otherwise what happens with these things is you educate the people who are involved right now, but what you really want to do is manage a legacy with this. So this is just a work in practice that just continues all the way through the department. And
also we talked about those sort of patients who are unfortunately not stageable for various reasons, but also quite commonly when they're presented at an MDT, you're wanting to discuss them promptly and, you know, get going with treatment, and you haven't got all the information yet for full staging. So it's not all there necessarily at the MDT. So you need other opportunities to go back to and backfill that data for sure.
Yeah, and I've just seen a comment actually saying at University Hospital of North Midlands, they have a dedicated COSD lead who's able to support the cancer services team, the MDT coordinators, and closely supported by your team, Simon. So that's really good. I think it is that link actually, as I say, often the cancer services team is quite separate from the MDT coordinator. So this works really well. Yeah, so it does sound like that model worked in some places, and definitely helping with their data collection. So you and your team are going to be in demand now.
Excellent. I'm sure they'll be eager.
Excellent. Excellent. Okay. Did you want to make any further comments, Simon?
No, I'll mute my microphone now and let the rest of the presentations go on. Thank you.
Excellent. Okay. So I think we're going back to you, Kate.
That's right, yeah. Let me share the slides again.
Slides.
I don't have too many more to share, so it's just wrapping up now. Okay. So I just actually wanted to show you, because I did have this slide earlier, but we didn't really focus on it. This is the problem. So we've got here from our dashboards, which actually were published today. They were updated. So I've taken a screen grab from today's updated one. And you can see here that we've got really wide variation between trusts on data completeness. And actually the Homerton, I think, is the 4th in this list. When you're on the actual dashboard, you can hover over any of these bars and it will show you which trust it is. This is just a screenshot of them. And it will give you your trust and it will give you the other trusts in the Cancer Alliance. So you can see really there's potential, isn't there? Obviously, in that graph, you can see there's potential for improvement for people moving from the right-hand end of the graph over to the left. Sorry to pick on you, David. I've picked your trust on there. Thought I'd bring it to life.
It can show us how much it's always easier to improve from a lower baseline. That's what I say.
True, yeah. Anyway, so just next steps and a summary. In the coming weeks, then we'll be sending out the bespoke feedback by email, giving you your own results for the trusts with the less than 50% completeness on Arbor. So expect an email, David. And then also a link there to a form where you'll be able to request support direct from NDRS. So people like Simon available to help. It is focusing on the lowest performing trusts on data quality, but that's not to say everyone else is off the hook. We're encouraging all trusts to use our dashboards, to make use of NDRS support, to learn from each other on how data quality can be improved. And, you know, apart from anything else, obviously, we all want better quality data. We need that to understand care. But also we do outlier report. At the moment, we're outlier reporting on survival in this audit, and we need accurate risk adjustment. And often, actually, when audits start outlier reporting, the potential outliers that are identified often highlight issues with data quality. So in order to avoid that happening, it's really worthwhile getting the data completeness improved. It's natcan.org.uk. You'll find links there to our data dashboard. There's also the key COSD items that we're asking you to focus on and other quality improvement resources. There's our email address there, and to say we will be evaluating the success of this intervention ongoing each quarter with the dashboards, and then again around a year after the start of the intervention. This is our website. This is on the right. This is a list of the key COSD items. It carries on after this, the list you can see here, but find that on our website. And that was all for me.
Excellent. Thank you very much, Kate. I think this is quite exciting, actually, that we might all move from the right side of the graph towards the left. I'm glad you focused on Oxford and not Leeds. I'm not sure where we'd have been on there. It's a bit like a leaderboard on Strictly or something, isn't it? There's going to be quite a lot of movement, I think. But I think that's what's really quite exciting about this, that I think there's probably quite simple measures that we could all do working together as a team that could really improve the quality of the data that's been provided to you. So I think that's excellent. So thank you very much. So are there any further questions from anyone. I don't know if any of the team want to make any further points, or any members of the team want to ask any particular questions. Is there anything? Yes, Simon would like to ask a question.
Sorry, this might seem...
Or make a comment.
Yeah, this might seem insignificant. Just if anyone's on the call and thinking of reaching out to the data liaison managers, our contact details are on the NNHLA FAQ page under one of the drop downs about completing. I think it's titled, "How do I check my data submission to NDRS?" Yesterday, I noticed one of my colleagues had a strike through their name, which was Marianne Mollett. So if anyone is coming from the kind of southeast east side of the country on this call, Marianne is still in post. That will be, I think, rectified. But yes, that's where you can find our contact details if you want to make the first step.
Excellent. Thank you very much, Simon. I think that's really important. Yes, it'd be interesting actually to look at, I'm not sure, just looking at the people on the call, exactly where everyone's from. So it'll be interesting to look at the sort of representation of the group here today as well. So, you know, and if there's other areas we should target. Yeah. Kate, do you want to come in?
Yeah, I just noticed that Frank Burrows has joined us. So I didn't know if you wanted to say anything, Frank. I did give a quote from you earlier. I don't know if you were here.
Are you with us, Frank? Can you hear us? Yeah.
I think Frank is with us, but he can't comment because of the setup with the team site. But Frank would be very welcome to put anything into the chat or the Q&A.
Yeah. Okay. So there's just a question about whether the presentation is going to be accessible for people who couldn't attend or have a copy of the slides. So I presume, Vicky, you're going to make that available.
Yes, Steph has kindly arranged that she will share the recording with us, and it will be added to our web pages, and we'll be sharing it via our social media channels too, I suspect. Yeah.
So, perfect. Thank you, Vicky. Fane, Lou, I didn't know if there's any further comments you wanted to make.
No, there's nothing for me. I was trying to highlight the question, or the latest one, about whether this presentation is going to be shared somewhere.
Okay, you're doing very well, Lou. You're managing the chat, so chat and QA, so thank you. Okay, David, any further comments from you?
No, I don't think so. No, I found it really useful. I hope that other attendees have, and you know, people who watch it back will find it useful as well, I'm sure. So productive evening, I think.
Yeah, I think that's right. I think it has been very useful. I think sometimes a busy day, you think, how am I actually going to be able to improve this? But I think really just talking through this, I think I can see quite simply how in our institution we can improve it, and I hope the rest of you can. And do share this information. And there's lots on the website. Looking at the dashboards, really quite good fun, because you can look at your trust and other trusts and how you can compare. And I think just things like the State of the Nation report, just reading that, understanding what the audit is all about. And, you know, we're really keen for this to be a success and to make changes, because, you know, this is the first haematology audit there's been. So we're very pleased that this has been included really within that can. So it'd be really nice if we could make a difference with this. So I think we can probably conclude here, really. I think this has been really excellent discussion. Very grateful to you joining at this time of the evening. So enjoy the rest of the evening. Thanks very much for all the team that have spoken. Thank you very much for Simon for your insights. It's going to be good working with you. And thank you very much to BSH and to Steph for hosting this tonight, and really pleased with that collaboration as well. So thank you all very much for attending, and have a good rest of your evening. Bye for now.